So as we know that breathing exercises are important for the general well-being of the human system. So breathing means taking in and out the air. So it can be modified in various ways so that it can serve lot of purposes for the benefit of your human system. So if we have to summarize the goals of the breathing exercises, then breathing exercises can be used to promote relaxation, to facilitate removal of secretions, strengthen your respiratory muscles, inspiratory and expiratory both, to mobilize your thorax or chest wall, to promote adequate ventilation and to reduce extra work of breathing. So probably we will be going in detail to each and every goal, and we will discuss that how we can modify the breathing exercises to achieve a particular goal. So first of all, we will start with the techniques to facilitate the removal of secretions. So we all know that due to various lung conditions and condition other than the lung conditions as well, we developed the accumulation of secretions at times. So secretions, sometimes patient is not able to cough out properly, maybe because the channel, the bronchioles or everything else is constricted. So patient is not able to do effective coughing, or patient is not able to effectively expel out the secretions. So in that case, if we have to assist the patient, then there are certain breathing techniques that we are going to discuss now. Out of that, one very important technique is active cycle of breathing technique called as ACBT. So ACBT is also called as forced expiration technique. So this entire technique basically consists of 3 phases, right? So the 3 phases are breathing control, thoracic extension exercises, and FET huffing. So before we discuss these 3 phases, do you understand the difference between huffing and coughing? So huffing is basically you are expelling out the air with your glottis open, like, and coughing is expelling out with your closed glottis, guys. So these are 2 different techniques. Coughing and huffing are not same, this everyone should know. Huffing is a low impact expelling technique and coughing is more strenuous. So if in any case we get a patient who just you're seeing a patient on a second or third post-operative day. So I'll suggest that, and if a patient has pulmonary complication, so I will suggest that we should start with the huffing, and as the patient improves, as the endurance of the patient improves, then we can progress to the coughing. Okay, now again coming back to the active cycle of breathing technique. So this entire technique, like I said, consists of 3 phases. So the first phase is the breathing control phase. So before, how we will position the patient, for how long you should give this ACBT to the patient, or how many cycles of frequency of giving this technique to the patient, that we will discuss later. But before that, we will discuss the 3 phases. So first phase is breathing control phase. Always remember, when you go to the patient is in a very anxious state most of the time. Either the patient is very tired because of the existing condition, or maybe the patient is very anxious and the patient has come from the operation theatre immediately. Because as physios, we at times have to attend the patient on the very first post-operative day. So the very first step in ACBT is breathing control. Breathing control means diaphragmatic breathing control. We all know where a diaphragm lies. Okay, so when we teach quite tidal breathing to the patient, means you are not asking the patient to go for the deep breath, but you are asking for the tidal volume breath, right? Like the instruction that you will give to the patient: breathe in from your nose and take your stomach out, and then breathe out from your mouth. So this is the tidal volume breathing. You always have to remember, you won't ask the patient to take a deep breath. Most of the students, they do the same thing, and they will ask the patient to immediately go for the deep breathing phase. No. First of all, you have to go for the breathing control phase, that is the tidal volume breathing, right? And for how long you need to teach this thing to the patient, for how long patient will be in the breathing control phase as long as you see the signs of relaxation in the patient. Okay, till then the breathing control phase should continue. It can continue for 30 seconds, for a minute, or for 2 minutes, or for 3 minutes as well. So clinically, there are certain signs that will tell you that okay, now patient is ready for the second phase. So breathing control, if the patient is getting calmed down, you can see the stress will go away from the face. Patient respiratory rate will get stabilized. The heart rate will also get stabilized. And if you ask the patient, are you feeling relaxed? Patient will definitely say yes. Again, one thing to remember, ACBT cannot be given to the unconscious patient. So one thing is the patient should be conscious, oriented and active to participate in the ACBT. Okay, please never try and give this technique to any unconscious patient. Okay, never say it like that. Okay, so breathing control phase will continue till the patient's respiratory rate gets settled down. Okay, next comes the thoracic expansion phase. Now you will ask the patient to take a little more deep breath, not the complete breath, but till the middle lung volume breath. Okay, we all know where are the segments, lateral thoracic segments. Okay, so you'll ask the patient, you'll place your hands on the lateral side of the chest of the patient, and then you'll ask the patient to take a mid-volume breath. The instructions will be raise your abdomen up and then raise your lateral chest also outward. Okay, this is what you are supposed to tell the patient. पेट फुलाइए और साथ साथ धीरे धीरे अपनी छाती को भी फुलाइए. Okay, and then you will ask the patient to hold that inspiration for minimum 2 or 3 seconds or as the condition of the patient allows. So what happens if we ask the patient during the thoracic expansion phase to go for the inspiratory hold? Inspiratory hold is very beneficial for the patient. The patient can sustain that because inspiratory hold helps in collateral ventilation. I don't know whether you have heard about this term collateral ventilation or not, but collateral ventilation means that when you go for the inspiratory hold, the air reaches out to the maximum number of alveoli. Okay, so in that way, in a layman, if I have to say, then there will be a uniform distribution of the air if you are going for the inspiratory hold. So in thoracic expansion exercise phase, we will encourage the patient to go for the inspiratory hold. Okay, clear? Okay. So now, after the breathing control, you are teaching the patient thoracic expansion exercises phase. Now, maybe, probably, or it can happen that in some patients, the moment you start with the second phase, the patient's respiratory rate will start fluctuating, or it will go up, or patient will start coughing out a lot, okay, or maybe patient will start feeling restless. So if you see any such signs, then immediately you have to switch back to the phase 1, that is breathing control phase. So you see, clinically, it is very important that you keep an eye on a patient during the entire procedure. Maybe patient will not be able to say many things, but if you will look at the patient, your observation should be so strong that you should know now I should stop and now I can start again. Okay, so if the respiratory rate, heart rate or the distress increases post second phase of ACBT, then you will again go back to the breathing control phase. Again you will start with the normal diaphragmatic tidal breathing, and then again you will retry with the thoracic expansion phase. I hope so it's clear to everyone. And then comes the third phase, which is your huffing part. Okay, forced expiratory technique, that is huffing. In huffing, what you'll ask the patient to take a deep breath in this phase, you'll ask the patient to take a deep breath. And then you'll ask the patient to huff like this. Now this huffing you need to teach the patient. Patient won't understand. If you will say, okay, now you have to do huffing, patient won't be able to do that. So first of all, very important is that your communication with the patient should be very clear. Patient should understand that what you are trying to get from the patient. Okay, what you want patient to achieve. So before you start with the cycle or before you start with any technique, you need to orient the patient about the technique, that what you are actually expecting out of the patient. Huffing is something that if the patient will not perform, then secretion will not come out. So what we have actually done when we did the breathing control phase and the thoracic expansion phase, we basically mobilizes the secretion so that they can come, to the central airway. Now we want those excretions to come out. But if the huff is not performed correctly, it won't happen. So how can you teach huff to the patient? You can tell the patient like you blow a candle with open mouth. Okay, try that. Or at times fogging of the mirror. You can teach the patient that like how you fog the mirror. Okay, like that. Clear? So this first of all you need to teach the patient. Then the instructions will be take a deep breath. How patient will take a deep breath? Raising the abdomen, chest, and then apical area up, and then huff. Like that. So patient can perform 3 to 4 huffs. Again, these, the frequency of huff or the frequency of the cycle will depend upon the condition of the patient. So there is no hard and fast rule that it should be this much or that much. Clear? Are these 3 phases clear? Breathing control, thoracic expansion, and Acbt, that is huffing phase. So once the patient is done with the huffing phase, I really want all of you to do the huffing once. Take a deep breath and do the huffing, all of you. Do it 3-4 times. Again. Very good. One more time. So you all can notice, you people are not having any pulmonary dysfunction. But in patients who got a compromised respiratory system, in those patients, if they will do continuous huffing for 2-3 times, so because of that, their bronchial resistance increases. They'll start feeling tired, and maybe at times some patients will start getting wheezing also. So the moment you finish with the huffing part, immediately you have to restart with the breathing control phase. And then you can end the cycle. That will complete your 1 cycle of Acbt. So 1 cycle of Acbt, breathing control, thoracic expansion, huffing, and then again teaching breathing control to the patient, and then your cycle, 1 cycle is over for the patient. Is it clear for everyone? Okay. So this is very, very, very important. At times, when patient performs huffing, maybe after that patient wants to cough out also. So maybe in some patient you can give the instruction post huffing, ask them to go for 1 major cough. Like if I do 3 times huffing, and then 1 strong cough. That will again help the patient to expel out the secretion efficiently. And then again you can start with the breathing control phase. Clear? So clinically, it's up to the therapist to modify the frequency, the steps of the Acbt as per the condition of the patient. I am repeating it every time so that you just don't go and perform the entire cycle. Patient is saying, oh, my heart rate is going up, and you're performing the entire cycle again and again. Fine, is it clear? So this is what is about Acbt. So what should be the technique, and for how long you can give Acbt to the patient. So first of all, you can go through these phases. So the first is the breathing control phase. You all can breathe the normal diaphragmatic breathing or normal tidal volume, like we discussed. It should be continued till the patient is. It should be continued till the patient is relaxed. Okay. Then comes the thoracic expansion. Chest percussion, shaking or vibration can also be performed during the phase of the thoracic expansion. So we all are clear about the percussion and vibration techniques. Okay, so if the condition of the patient allows, while the patient is performing the thoracic expansion, you can simultaneously give the percussion and vibration to the patient. That will further help in loosening of the secretions. Okay, again as per the condition of the patient. 3 to 4 thoracic expansion exercises you can give to the patient. Inspiratory hold maximum 3 seconds. I'll suggest maximum 3 seconds is okay for the patient if you're seeing the patient in an ICU setup. Okay? Okay. Next comes your FET phase, which consists of huffing. First huff from middle to low lung volume. Second huff from high to middle lung volume. 1 or 2 huff can be performed, and then again you have to switch back to the breathing control phase. Okay, so this is the entire cycle of ACBT. Now, in which position you can take the patient? You can take the patient in a sitting or upright position, horizontal sideline position, or a postural drainage position. See, the ideal position is, the best way or the effective way of incorporating ACBT is if you can take the patient in a comfortable position, no doubt, but you can take patient in a position where the secretion can be assisted. So postural drainage is one position in which gravity, there are postural drainage positions for different segments of your lung. Okay, so gravity assisted facilitation of secretions is there in the postural drainage. So if you take the patient in a postural drainage position and you are performing ACBT, along with that you are giving percussion and vibration to the patient as well, that will have amazing results in the patient. Okay, so which position you will choose? You don't have much choice. The patient is in ICU setting, you can take the patient in a horizontal sideline or in a recumbent position. Okay, or if the patient is like not on oxygen or any other way, then you can take the patient in a sitting position as well. Okay, why sitting position is the best position for giving the ACBT to the patient? Anyone? So it is because when you are when you're in a lying position or you are in a sideline position, one or the other area of your lung is supported, right? Lung is supported in the sense it is compressed and it is supported. So when you take the patient in an upright position, the posterior area of your lung, the largest area of your lung is present posteriorly. Remember in post-COVID also, patients were encouraged to lie down in a prone position, and that effectively improved oxygenation in many patients immediately. Immediately in the sense, within 15 to 20 minutes, oxygenation of the patients got improved. So in the same way, while you are giving ACBT to the patient, encourage the patient, if possible, if the condition allows, to give ACBT to the patient in an upright position. Okay, because when the patient is in an upright position, patient will use the posterior area of the lungs also effectively. Fine. So ACBT cycle you can repeat 2 to 3 or 3 to 5 cycle. Okay, and can give rest to the patient in between. And once you auscultate that the secretions are less or the air entry gets improved, then you can remove. Then you can stop. Okay. The best part is that you can give ACBT technique to the patient as a home care program also. So see, being a patient at times they get discharged very soon. We are not able to complete their pulmonary rehab and they get a discharge. So at home, if we want the patient to achieve the best result, so ACBT, if you teach patient effectively, then patient can perform on its own and can get the results effectively. Okay, so this thing is clear. Okay. So these are some of the references that support that ACBT is very much effective in certain pulmonary conditions like bronchiectasis, and like there is this one reference that says ACBT when incorporated with PD, that is postural drainage and vibration, is a more effective method of airway clearance in bronchiectasis than TIA during single treatment sessions. So there are a lot many such references that supports the effectiveness of ACBT. Okay, so next we will move on to the next airway clearance techniques or forced expiratory technique, that is autogenic drainage. So this is another technique that facilitates the removal of the secretion. Auto drainage means it again involves certain sets of breathing exercises that automatically will give a way for the secretions to come to the central airway so that they can be expelled out clearly. Okay, so basically it consists of 3 phases. It consists of unsticking phase, collecting phase, and evacuating phase. So like in unsticking phase, you'll ask the patient to take normal inspiration with breath hold for 2 to seconds for collateral ventilation to go up, as we discussed previously as well. And then you'll ask the patient to go into expiration into expiratory reserve volume phase. This is called as low lung volume breathing. So in this unsticking phase, you'll ask the patient to go for the normal tidal breath, normal tidal breathing, raising your abdomen up, no deep breath. Then you will ask the patient, while the patient is doing the expiration, you'll ask the patient to go into expiratory reserve volume. What does that mean? You'll ask the patient to empty, the instruction will be empty your breath completely. Till end. This is expiration into the expiratory reserve volume phase. No air should remain inside. Patient should do expiration as long as possible for the patient. So this is called as unsticking phase and low lung volume breathing. Is it clear? You take a normal tidal breath, then breathing out in expiratory reserve volume. Empty your breath completely. Okay? Then comes your collecting phase. So when we are talking about the phases, you can make up unsticking phase mean it will help in loosening of the mucus. Okay. Then comes your collecting phase. So this phase, when you are doing this phase, it will help the secretion to collect in the central areas. Okay. So this phase is basically it incorporates low to middle lung volume breathing. Okay. So in this, we'll ask the patient to do tidal volume and increase the tidal volume to inspiratory reserve volume range. We are clear about the inspiratory volume range? No? So you will ask the patient this time not to go for the tidal breathing. You will ask the patient to do the tidal breathing and then you will ask the patient to take little more air inside. That is called as middle lung volume breathing. Okay? So you will ask the patient do the tidal breathing and thoda sa और लंबा सांस खींचो आप. Like that. You'll ask the patient to take a normal tidal volume breath and then you'll ask the patient to take little more breath till mid-lung volume. Okay? And after that, you'll ask the patient to do the normal expiration. Not into expiratory reserve volume this time. Okay? Clear? This is called as the collecting phase. Then third phase is the evacuating phase. Now in this phase, you'll ask the patient to take the full deep breath into the inspiratory reserve volume. Okay, and then we'll ask the patient to perform a high volume huff like we performed in Acbt. So the patient will take a very long deep breath and perform a high volume huff. See, there are basically three volumes huff: high volume, middle volume, and low lung volume huff. Okay, so high lung volume huff will help in expelling out even the deeper secretions as well. So low volume huff is you took a tidal volume breath and perform huff. Middle volume huff is you did inspiration into the middle lung and then you perform the middle lung like this. High volume is take a complete deep breath inside and then this is high lung volume huff. So you all can perform it on your own. Perform the low lung volume huff first and then the middle lung volume huff and then the high lung volume huff and see the difference. All of you please together. First you perform the low lung volume huff, tidal volume breath and huff, and then middle lung volume breath and then mid volume huff, and then complete deep breath till inspiratory volume and then high volume huff. Okay, so you all can see that secretions move very much effectively when you perform the high volume huff. So this is all about the autogenic drainage. Autogenic drainage and Acbt, they resemble each other. So it is up to you that which technique initially you would like to start with the patient, or you can get both the techniques to the patient once the patient is getting a discharge. Okay, so there are some advantages of autogenic drainage. It has been seen that greater saturation of oxygenation or greater oxygenation is being seen in the patient post the autogenic drainage phase. Same like in Acbt, in autogenic drainage also you can give percussion vibration to postural drainage position to the patient. Again, sitting upright position is the most suitable and the most complementary position for the patient. But otherwise, as the condition of the patient, you can take patient in sideline or recumbent position. So as of now, this much we will discuss. Rest we will cover in the next class. Thank you so much.